So hello, my name is Eric Lowe. I'm a gastroenterology fellow at the University of California, San Diego. I wanted to thank the AMS committee for allowing me to talk today. I gave a talk here at ACG yesterday about the risk of esophageal cancer in achalasia. So I'll talk a bit about that. As we know right now, achalasia is a postulated risk factor for esophageal cancer. The suggested pathophysiology relates to stasis esophagitis. Esophageal cancer-associated risk and outcomes in individuals with achalasia have been understudied, and as of now, there are no current guidelines for surveillance endoscopy in those with achalasia. So what we did for our project is that our aim was to look at the risk of esophageal cancer in those with achalasia compared to those without achalasia, using a large validated cohort called the Veterans Affairs Achalasia Cohort, or VAAC for short. Within our study, our participants included those that were 18 years of age or older that were cared for within the Veterans Health Administration from 1999 to 2020. Our primary exposure was a diagnosis of achalasia, and our primary outcome was incident and fatal esophageal cancer cases, which were all manually reviewed for verification, as well as histology, location, stage, and mortality. In our study, we used a matched cohort design where we matched individuals with achalasia to those without achalasia at a ratio of 1 exposed to 4 unexposed. Individuals were also matched based on sex, birth year, as well as first VA visit, which allowed equivalent follow-up time within the VH system from the time they entered to the match date. Then patients were longitudinally followed from the matching date until they met one of the following outcomes, either the primary outcome, again, which was incident or fatal esophageal cancers, a death from a non-esophageal cancer-related cause, or the end of the study period in 2020, whichever happened first. We then computed survival analyses to look at cumulative incidence as well as relative risk for esophageal cancer. The results of our study, so our study included 9,330 total subjects. Of those, there were about 1,866 individuals with achalasia, which were matched to 7,464 individuals without achalasia. In terms of age and sex, those variables were similar between the two analytic cohorts because these were variables that we matched on. BMI was also similar between the two analytic cohorts. Those with achalasia compared to those without achalasia had a higher proportion that were Black, Hispanic, and then had some exposure to smoking, either current or former smokers. Now to kind of the main results of our paper. Again, the primary outcome was incident or fatal esophageal cancer cases. Within our achalasia analytic cohort, there was about 12,000 total person years of follow-up time from the matching date onward, during which there were 17 incident esophageal cancer cases that were diagnosed. 12 of those were squamous cell carcinoma, 3 of those were adenocarcinoma, and then 2 of those were of unknown histology. And the total incidence was 1.4 cases per 1,000 person years. Within our non-achalasia analytic cohort, there were about 48,000 total person years of follow-up time, and during which there were 15 incident esophageal cancer cases that were diagnosed. 1 of those was squamous cell carcinoma, 11 of those were adenocarcinoma, and 3 of those were of unknown histology. And the total incidence for esophageal cancer within the non-achalasia cohort was 0.3 cases per 1,000 person years. With that data, our main finding for our abstract is that there is an unadjusted hazard ratio which shows a 5.4-fold increased risk for esophageal cancer among those with achalasia compared to those without achalasia. The cumulative incidence for achalasia, and I showed a Kaplan-Meier curve yesterday during my presentation, but at 5 years of follow-up time, the cumulative incidence for esophageal cancer in our achalasia cohort was 0.8% versus about 0.2% in the non-achalasia analytic, in patients without achalasia. About a 10 years follow-up, the cumulative incidence for esophageal cancer in those with achalasia is about 1.5%, which roughly works out to about 1 in every 67 patients with achalasia. And the cumulative incidence of esophageal cancer in those without achalasia was about 0.3%, so much lower, and that was statistically different between the two exposure groups. The last bit of information I'll share is that during our manual review of all the esophageal cancer cases, one pattern that we found that we thought was interesting is that a lot of cases actually had a diagnosis of Candida esophagitis that preceded their diagnosis of cancer. And so that prompted us to do a post hoc analysis using administrative claims codes to look at the proportion of those that had Candida esophagitis among those with cancer and those without cancer. And within our 32 cases of esophageal cancer from our entire study, there were 4 or 12.5% of those, 12.5% had Candida esophagitis that preceded their diagnosis of cancer. And among those without esophageal cancer, the proportion of those with a lifetime diagnosis of Candida esophagitis was only 0.7%. This led us to our final result, which showed an unadjusted hazard ratio, which showed 18.3-fold increased risk for esophageal cancer among those with Candida esophagitis compared to those without Candida esophagitis. Of note, all of those that had Candida diagnosed before their cancer also had a diagnosis of achalasia. And those with Candida, the median time from Candida diagnosis to cancer diagnosis was about 1.8 years. And so what we concluded from our research thus far is that within a population-based nationwide cohort of individuals with achalasia, we found a 5.4-fold increased risk of esophageal cancer in those with achalasia compared to those without achalasia. And the implications for this are that individuals with achalasia should have a high index of suspicion for esophageal cancer during any endoscopy procedure and should benefit from surveillance endoscopy looking for cancer in the future. The question becomes now kind of what interval of time should this be that we should be surveillancing individuals with achalasia to find these esophageal cancer cases. Again, the latter finding, which is interesting and kind of hypothesis generating, is that we found that Candida esophagitis was associated with esophageal cancer risk. I think more research is needed to understand whether Candida is directly related to cancer pathophysiology, or it's just a manifestation of severe stasis within the esophagus that's kind of leading to these cases of cancer. There have been some postulated mechanisms for Candida inducing cancer, and there has been some research in squamous cell carcinoma and Candida in the head and neck area. So it's possible that it could be its own kind of disease process leading to cancer, but again, more research is needed in this area. Those are our main findings, and luckily I was able to share with kind of a large audience yesterday at ACG our findings, and we hope to publish this soon and go on to bigger and better things. Thanks so much.